Welcome to the debate. Today we're diving into a really fascinating topic, the rigorous protocol for creating individualized orbital reconstructions using CAD/CAM technologies. This is something that it's completely changed how we approach complex craniofacial trauma, especially when the orbit is involved and you're dealing with issues like double vision or, major volume problems.
It really has. I mean, the shift away from a surgeon just sort of manually bending a piece of titanium mesh in the operating room to creating these perfectly precise patient-specific implants, it's probably the single biggest leap forward in modern maxillofacial surgery. It demands an incredible level of precision.
And that precision is what we're going to focus on. We're drawing from established clinical protocols to really ask a central question. Which stage of this entire CAD/CAM workflow is the biggest hurdle? Where's the highest risk of failure? For my part, I'm going to argue that it all comes down to the beginning, the data acquisition and segmentation. If that digital foundation isn't perfect, nothing else matters.
See, I'm not so sure. While I'd never argue that the data isn't important, it's obviously the starting point. I think the greatest challenge, the real complexity and where the most expertise is demanded, lies in what you do with that data. It's in the CAD modeling, the tough choices you make in material selection, and ultimately the final surgical implementation.
All right, well, let's start with that digital foundation then. The technical requirements for just getting the data they're incredibly strict. You can't just use a standard trauma CT you'd get from the ER. We're talking about needing high-resolution spiral fan beam computer tomography, FBCT, with extremely thin, non-overlapping slices. Think 1 millimeter or even better, 0.625 millimeters.
And that's to avoid the stepping artifacts, right?
Exactly. If you have big gaps between the slices, you get this jagged, stepped surface on your digital model. And an anatomical model with those kinds of artifacts it's guaranteed to be inaccurate. But it's more than just the slice thickness.
It's about seeing the soft tissue too, not just the bone.
Precisely. The filtering you apply during the scan is just as critical. The protocol has to be set up to see not just the dense bone, but also the orbital fat and the extraocular muscles at the same time. If your initial scan can't do that, the designer is flying blind. They can't answer the key questions. Is a muscle trapped? How much volume do we actually need to add? If you can't see the soft tissues, the whole design process is essentially paralyzed before it even starts.
Okay, I will absolutely concede that garbage data in means garbage implant out. The entire process is a non-starter without a good scan. But, and this is the core of my argument, the real intellectual heavy lifting, the place where the most sophisticated problem solving happens, is in the manipulation of that data and managing the clinical trade-offs that follow, the CAD phase. It's not just mapping a surface. It's an active design of conceptual correction.
So what part of the design do you think is more difficult than getting a flawless segmentation of both bone and soft tissue to begin with?
Well, let's talk about the primary method, mirror imaging. This is what we use for most unilateral defects. The designer has to find perfectly symmetric, non-fractured reference points, like the upper orbital rim or maybe the zygomatic arch on the healthy side, to perfectly align the mirrored good side onto the damaged side. Now, imagine a patient with severe panfacial trauma. Finding any reference point that's truly untouched and symmetric, it becomes this incredibly difficult geometric puzzle.
But that still requires a clean defect to fill in the first place.
It does, but the challenge is bigger than just geometry. Think about chronic fractures. They often come with secondary problems like orbital fat atrophy. That's what causes that sunken in look in ophthalmos. So to fix that, you need to do something called hypercorrection. You intentionally design the implant to be a little thicker, to slightly over-reduce the orbital volume, to push the eyeball forward and compensate for that lost tissue. That requires an implant with these complex, smoothly varying thicknesses across its surface. And that kind of predictive design, you're designing for a biological change that's happened over time. That is conceptually orders of magnitude harder than just getting a clean CT.
Yeah, that's a good transition into what I see as the core conflict, the raw data artifacts versus the design methodology. Because while hypercorrection is complex, let's go back to the technical nightmare of getting an accurate segmentation in the first place. Turning that grayscale CT image into a measurable, solid model. The biggest problem here is something called pseudo-defects. false holes. They show up all the time in the super thin walls of the orbit.
Yeah, the paper-thin walls, especially on the floor and medially. The scanner has trouble resolving them.
Exactly, and when the software can't see that thin, bony barrier, these pseudo-defects basically merge the orbital space with the sinus next to it, the maxillary or ethmoid. And here's the critical point. That eliminates the boundary. If the computer can't define the edge of the bone, it can't define the size or shape of the hole you're trying to fix. So to get around this, the designer has to do this really aggressive and time-consuming manual edit. They have to go into the raw data and virtually paint in a solid wall by replacing the air in the sinus with a maximum brightness value, just to trick the software into seeing a boundary that was actually there all along.
And I'll concede, dealing with those pseudo defects is a huge headache. It takes a lot of technical skill in image processing, but I think the ambiguity of mirror imaging in a complex trauma case carries a much higher clinical risk. It operates on this assumption of perfect bilateral symmetry, which isn't always true. If the patient had a subtle asymmetry to begin with, or if your reference points are even slightly compromised, the implant you design, no matter how perfectly it was segmented, is just going to lock in a bad anatomical position.
But if the segmentation failed and the geometry of the defect itself is wrong, the implant won't even fit. It won't see properly on the bone no matter how perfect your mirrored design was.
Okay, but the challenge of volumetric correction, of that hypercorrection I mentioned, it goes beyond just segmentation. The designer is using the software to compare the healthy side to the fractured side, yes, but they're not just finding a fracture line, they're creating a new shape where the thickness is constantly changing based on the distance between the ideal mirrored surface and the patient's actual broken bone. It's the skillful modulation of that thickness that requires deep surgical and anatomical knowledge, not just digital cleanup skills.
Let's shift focus then to the next stages, manufacturing and materials. Because this is where I would argue those early data flaws just get amplified into potential disasters.
I'd say this is where the true engineering complexity comes to a head, the CAM phase, the actual manufacturing. It forces you into these material trade-offs that have huge clinical consequences. Take two common materials, PUMW, which is a type of polyethylene, and zirconium oxide.
Right, the polyethylene is popular. It's easy to work with.
It is. It gives a surgeon a safety net. You can drill it, you can trim it, you can make little adjustments right there in the OR. The huge drawback, though, is that it's radiolucent. It's basically invisible on a post-op CT scan, unless you embed tiny titanium markers in it just so you can see where it is. Now, on the other hand, you have zirconium oxide or milled titanium. They're rigid, they're highly radiopaque, so you get great post-op imaging, but you absolutely cannot adjust them in surgery.
Which means the digital design has to be flawless from the very beginning.
Flawless. For zirconium, you even have to build in a 20% enlargement in the CAD file to account for the material shrinking when it's sintered. My point is, balancing that need for surgical flexibility against the need for post-op assessment, it's a series of complex engineering decisions that happen long after the CT scan is done.
I get the engineering challenge, I do. But let's bring it back to how that initial data can undermine even the best engineered implant. Think about a custom titanium mesh. It's modeled perfectly on a digital file. It's pre-bent on a 3D printed model. It looks beautiful. But if the geometric fit from that initial CT data was just a tiny bit off, you are still facing a huge risk of surgical failure.
Well, the malleability of mesh is a known risk factor.
Sure, it is the ultimate test of data integrity. The source material we're looking at shows this critical surgical error. Even a perfectly modeled implant can be seated incorrectly. If the front edge doesn't sit perfectly flush against the orbital rim, when you tighten that fixation screw, the back of the implant can pivot upwards, and that posterior elevation can press directly on the orbital cone or, in the worst-case scenario, the optic nerve. You could blind the patient. This just proves that a precise self-navigating fit, which you only get from perfect digital data, is the best defense against surgical error. The implant should only want to sit in one correct position.
The self-navigating concept is powerful, I'll grant you that. It simplifies the surgeon's job. It cuts down on OR time. The surgeon's first job is making sure the radiologist gets them the data they need to achieve that fit.
It's so critical that surgeons even use these clever little tricks, like a modified spatula with suture loops, just to gently pull the implant back to the posterior ledge and make sure it's seated perfectly deep without having to shove it around.
That just shows how important the fit is. But the absolute peak of technical complexity comes when you can't rely on fit alone, when you need to integrate that precision with active, real-time surgical guidance. This is for the really tough cases, the late reconstructions, the ones with a lot of scarring. That's when you need intraoperative navigation.
And that requires a whole other layer of digital work, well beyond the initial scan.
Exactly. We're not just talking about getting a good image anymore. The CAD designer now has to build a mechanical connector, a little mounting point, directly onto the implant itself so it can be attached to the navigation probe. Then, the implant's digital file, the STL file, has to be imported and registered into the navigation software. This process of linking a physical, custom-made object to a digital tracking system in real time, that introduces layers of technical complexity that dwarf the challenges of getting a clean image or even cleaning up pseudo-defects. Success there really hinges on mastering that integration.
So we're at the end of our discussion, and my position really hasn't changed. I still believe that the initial data acquisition and segmentation is the single point of highest vulnerability. The success of the entire, CAD-CAM reconstruction is fundamentally capped by the quality of that initial volumetric data. Without a flawless digital foundation, the most sophisticated design work, the most advanced materials, they just can't compensate for a model that doesn't accurately represent the patient's anatomy.
And I'll conclude by saying that while that data integrity is the ticket to entry, you can't even start the process without it. It's the ability to navigate all the subsequent complexities that truly define success or failure. This means making that conceptual leap for hypercorrection, managing the critical trade-offs with materials, and at the highest level, integrating the implant with advanced surgical technologies like navigation. These are the steps that demand a true mastery of both engineering and clinical prediction, and that's where the greatest challenge lies.
I think we can both agree that this entire individualized CAD-CAM protocol is it's a paradigm shift in our field. It demands absolute precision from start to finish.
Absolutely. It's a chain of precision, from the radiologist following the scan protocol to the CAD designer's skill, all the way to the surgeon's hands placing and fixing that implant. The real value is in that rigorous technology-supported pursuit of perfect anatomical accuracy.